So thank you very much. So already had introductions from Juliet, thank you. And I've worked at WWL for the last 8 years and done a lot around staff engagement and culture in my capacity as an occupational psychologist and director of OD, deputy director of OD. So this piece of work I'm going to talk to you about is actually what we did to respond to the COVID-19 pandemic from a psychological support perspective. So even before COVID, we had a mental health crisis in the NHS. It was a significant issue. Many organisations seeing signs of burnout, stress-related sickness absence, presenteeism. So when COVID came along, all that was going to do was exacerbate the situation. And what COVID brought with it was some significant additional pressures on staff. And it was highly unfamiliar, challenging circumstances for them. And early on as an organisation, we anticipated the psychological impacts that these challenges would bring for our staff. That included things like anxiety, exhaustion, emotional impact, and actually an increased prevalence of mental health difficulty. So the knock-on effect of this would be potentially deterioration in staff well-being, increase in absence, potential for actually staff to leave the profession. And since the pandemic began, the national figures are actually identifying that 1 in 5 staff have experienced depression, 1 in 8 have developed severe depressive symptoms, 43% have developed a general decline in mental health. So in addition to staff working in addition to all that, staff working in critical care are actually twice as likely to develop PTSD symptoms that you would normally see in military veterans as well, who've just experienced combat. So this is showing that COVID is having quite an impact on staff. And staff are our most important asset, aren't they? In March 2020, we prioritised the establishment of a model of psychological support for our staff in order to address all levels of psychological need. And our aim really was to try and prevent both the impact, the psychological impact this would have on staff, but also trying to keep our staff healthy, supported and well in work. So this slide, it just kind of starts to show really what our staff have experienced. Some of the things we know staff will have experienced during the pandemic have kind of gone through a sort of a change curve, really. Early on, we could see quite a lot of these signs of actually people feeling quite energized at the beginning, a lot of support from the public. And actually, as we started to go through the early stages, we certainly saw as an organisation a lot of anticipatory anxiety at the beginning. As time went on, a loss of control, tensions emerging, etc. And then as we started to go through more of the peak of activity around COVID, we started to see more signs of things like moral injury. So this included things like staff not feeling that they could really give the kind of care that they wanted to give to patients in this challenging time. So, for example, they might want to try and connect their relatives to patients. That's an important part of providing dignified care. And a lot of our staff were really hindered from that process because of the barriers in place around COVID, not enabling patients' relatives to come on site. So those are sorts of things that they would take home with them, they would ruminate about, they'd find really difficult as part of the care, the dignity of care that they wanted to provide. We also started to see more signs of burnout, self-neglect, emotional sensitivity. And this point as well, anybody who had a mental health underlying condition was also more vulnerable to the psychological impact of the context they were working in. So we were at quite a vulnerable point, really, from a staff perspective. And then this is kind of where we're reaching now. So we're kind of coming out the other side, a point of recovery. And this will offer time for space and reflection. But at the same time, this can be both positive and negative. So depending on the emotional response, we could see some examples of people recognizing the strengths, that they've gained, some of the positive experience that they've gained through this time, but also people starting to experience these feelings of shame or guilt, reflecting back on their experiences. And then actually, this is the point where burnout could start to set in for many people at this point. So we would expect to see potentially an increased prevalence of things like PTSD as we move through this recovery point onwards. So this is where we are, this is what we tried to do basically. We tried to address the psychological impact through our stepped care model. And so in order to meet our objectives, we wanted to tackle all levels of psychological need during this time. We didn't have all the resources we needed to do this at the beginning of the pandemic. And so early on, we made a business case framed around this model. And this is our stepped care model. So it ranges from level 1, just providing that preventative, proactive mental health support, right up to significant distress. So this includes everything from psychological assessment, intervention, managing complex needs. It's dealing with a much higher complex level of support for staff. We were given 12 months by our organisation to develop a proof of concept with the intention of demonstrating return on investment and investing longer term in mental health support for staff. Obviously, if we could demonstrate this was making a difference. So as part of this, we were able to recruit a senior clinical psychologist. We recruited psychotherapists and some wellbeing practitioners to support the resource that we had in place already. And it wasn't a broad resource that we had in place already. It was very basic, really, what we had, but we knew that we needed something more significant to get us through these next 12 months, potentially beyond. So I'm going to talk you through just a summary of some of the services we provided to give you a bit of a flavour of what we've delivered. And there is some evaluation of some of these interventions as well that I'll talk you through. So at level 1, we are providing a range of resources, communications channels, staff briefings have worked really, really well. We use these to help staff become aware of the potential psychological impact during the pandemic, understanding the how to signpost people to the right resources, support. It's all about awareness raising, really. So we've done a lot around that. We've also offered a lot around training. So we have something that we brought in called a 3-step process training program. And it's only 30 minutes, but it's actually just guidance on how to do a 3-step process of a post-shift wellbeing check-in. And people do it at the end of the shift. It helps to kind of talk through how have you found shift today? What are you going to do when you get home? How are you going to support yourself? How are we going to look after each other? So some simple tools and resources that we could build in to educate, guide, help people understand the need to support their wellbeing, their resilience. We've also brought in wellbeing leads, and we've got 6 of these. They're 6 senior professionals across the organisation, and they very much represent different roles. We've got one who's a consultant orthopaedic surgeon, we've got another who's a matron, another who works in the community. And on a bi-weekly basis, they go around the different sites of the organisation with an exec. You can see in the picture here that they're with our chief exec in this picture. And they conduct some wellbeing walkabouts. And that's just a chance for them to talk to staff about their well-being, how they're getting on, what are their experiences, and it's a good engagement exercise. And obviously we've brought in things like apps and all the kind of usual stuff that a lot of organisations have been bringing in. We've done the same. In addition, what we've also done, and this is at level 1 again, is we have developed and trained wellbeing champions. And we've got 152 of those now. The number seems to increase every time I check, because it's really a growing movement. We train them in psychological first aid, so they know how to signpost, provide that initial kind of signposting levels of support, and they can recognise some signs of mental health distress so that they can escalate that if they need to. And they promote wellbeing initiatives in their own area. And this is great because this scales out the level of support across the whole organisation. It doesn't sit within one team. It doesn't just sit within my team. There's a level of responsibility across the organisation for wellbeing. And then we've also offered proactive in-reach service to wards and departments, which my team do offer, but that's more on an ad hoc targeted basis. So over the pandemic, we've offered 108 sessions where we've gone towards areas, checked in on staff, had wellbeing conversations, signposted, offered them support. And again, the demand for this has actually increased over time. And staff have really valued having people come out and support them in their own working areas. Then kind of moving on to the next level, we've got what we've brought in was an EAP, Employee Assistance Programme, which again, I think a lot of organisations do have. We didn't have one for a few years, then we brought it back in again as COVID started. And actually what we've had with this is 70 calls between March and November. 12 of those were referred to counselling, and most of the calls are relating to anxiety, bereavement, low mood. So it's been just another offer we've been able to provide for people who just feel safer to have that external phone conversation. What we've also done as well is bring in SOS Reams. These are called a Sepsis support Reams, and this was quite a big undertaking at the beginning and had quite a lot of demand at the beginning as well. This is a safe space set up for staff across each of our sites, a bit like a wobble room. Other organisations have had things like wobble rooms. But staff could drop in if they were feeling distressed or anxious or needed to kind of offload. But what we did is we staffed those rooms with volunteers, often volunteers who were redeployed, who needed kind of some additional work and wanted to get involved. And we train them in a methodology called diffusing. So what diffusing does is it's a bit like an emotional cool down. So if somebody comes in very distressed, you give them a chance to kind of offload, and then you help reduce that emotional tension by helping signpost to how they can support themselves, what can they do, where can they get additional support, have they got people they can talk to, etc. So again, a lot of people came in early on with reasons relating to anxiety. The uptake has decreased over time, and we think this is a barrier due to access. People can't always get away at the moment from their working area to attend, and a lot of clinical staff are concerned about leaving patients. They don't want to step away from the work environment, and that's a cultural thing that we all need to think about, is how do we encourage staff to value time for themselves and support themselves as well as supporting their patients. If they look after themselves, they can look after their patients. So that's a barrier we need to overcome. But we did see more of a peak in activity during the recovery period over the summer. So again, we're expecting that we might start to see more people attending these rooms at this point now, because they will have the time and space to do that. We've also started running reflective groups. We brought in these as a way of staff to process their experiences. And this is probably more important in the recovery phase. We've had really good feedback for our Schwartz rounds that we started running from December. And we've also started to tailor some reflective sessions for different groups. So, for example, leaders who actually we know don't readily access support all the time. They are concerned often about trying to put the support in place for others, but don't necessarily recognise that they need to access support. So we set up leadership support circles for them. We're also doing bespoke groups for specific areas that need support. So for example, we did one recently with sonographers, not a group you would automatically think would be affected by COVID, but actually they wanted to share their experience of not being able to enable patients to bring their partners to antenatal scans, which was quite emotionally challenging for them if they identified an abnormality on a scan and the partner of the patient wasn't there. This was quite distressing and quite difficult for them to manage. So again, we gave them that reflective space to talk about their experiences, and how they felt going through that during the pandemic and not being able to do their job in the way they wanted to. We've also offered mindfulness. That's something else we offer. We have a mindfulness practitioner, which we kind of had to put on hold in terms of face-to-face delivery, but we're bringing back around now, and we've offered it kind of on an ad hoc basis as well to staff through in-reach sessions. And we'll also soon be offering psychological screening for staff. This will help support rapid access to mental health support in more of a timely manner. So screening can be a bit controversial, but we're using it in a way to offer rapid access to support for specific groups. The focus initially is going to be on critical care, with all staff being offered the opportunity to complete a self-report on screening measures confidentially, and allow for any clinical follow-up if staff are scoring above the normal range on these measures. And then psychological assessment and brief intervention will then be offered to them. And anybody who's scored severely high at risk or severely distressed, we then will be aware of them, will be able to fast track them to more specialist trauma support, or even access the GM Resilience Hub clinical team. So we're using it in that way to identify people early on who may benefit from some significant support. We've also utilised our CISM service. This is something we had in place already, but has really come into its own. CISM is critical incident stress management, and it's used to support trauma responses after traumatic events. It comprises of 3 methodologies: crisis management briefings, so that's aimed at communicating to broad groups and teams about information on sensitive, upsetting events. So for example, if a colleague has died, we did have some colleagues that unfortunately passed away from COVID, we would use a crisis management briefing to supportively communicate that information to that group or their colleagues. Diffusing, which I've already talked about, and then debriefs, which are more of a 3-hour kind of structured intervention. We also had a supplementary app that staff could access in their own time, or managers could access, to get guidance on how to support trauma responses. So this service in general has had really good feedback. We've been able to demonstrate in the past even its impact on preventing long-term sickness. So it's been really beneficial, and it's been important to use those interventions in the right way. It's not good to use debriefing when you're in the middle of an event or a crisis event. So we haven't used debriefs as much related to COVID, it's more about specific events, but the diffusing has worked really well throughout the pandemic, because it's more of an ongoing intervention. And then what we've also started to do is offer outreach call service to staff as well. So we've been contacting staff, we're piloting this at the moment, but we're contacting staff who are registering sickness absence relating to mental health reasons. We focused initially on registered nurses who'd been off sick for more than 4 weeks. So our wellbeing team would ask about their current difficulties, they'd offer signposting, they'd resources, further support options. The calls would then be discussed and triaged by a clinical psychologist to determine any further support needs. And from here then, staff would be offered any anxiety or bereavement group input for them, because there might be people who are off with a bereavement, for example. We've had 2 people who have been offered further assessment and intervention with the clinical psychologist and psychotherapist. And actually, we've also started to get some referrals from managers in HR into the clinical psychologist as well, to complete psychological assessment, formulation and intervention. So again, we've had good feedback for these sorts of services that we're piloting. And it's something that we want to be able to provide more broadly. It's fairly resource intensive, but actually something that could really support people when they're just at that point of just going off sick, or just kind of teetering on the edge, really. So that's something we're looking at further developing. Also, just to say as well, in response to the high numbers of staff reporting depression, anxiety, bereavement as their main difficulty, what we've started to do is correlate this to the most common reasons for staff contacting the employee assistance phone line. And so what we can see now is that there is this growing need around supporting anxiety, bereavement, loss. So we've also started to put in some therapeutic groups and some psychoeducation around this so that staff understand how to support themselves, managers understanding that this is a particular issue, how staff can be better supported. So again, that's another intervention that we're starting to try and offer in this area as well. And then just moving on to kind of more significant need, we've got counselling. So we are starting to integrate counselling that was sitting with occupational health into this model of care so that we can offer one-to-one, group, specialty counselling services, join it all up together as part of the model. We've also set up some referral pathways as well into local services to support more complex needs, because we can't support everything, and that's the important thing to remember is we're not a mental health trust offering mental health services. We are a team who are providing support for our workforce. So we can't be all things to all people, but what we can do is establish the pathway links that maybe staff wouldn't have understood how to access those or be linked into those. Normally, they would have to go through their GP and then be signposted, and that can be quite a lengthy process. So we've been able to set up those pathway links, staff accessing community support that they might have not otherwise engaged with. And this streamlines that access to those services, providing that assessment, referral process, all of those things linked together. And then we've also offered a post-COVID clinic to support staff with longer term COVID symptoms as well. And those that might experience things like cognitive issues, fatigue, etc. So in terms of overall outcomes then, so far since August, we've seen our stress-related sickness absence come down, actually below the national average levels, which is really promising and promising sign that the services are perhaps starting to have an impact. However, it's really important to be cautious about this, because what we could be seeing as well is signs of presenteeism. So the recovery stage is going to be really key to see if we start to experience a further increase in or higher prevalence of burnout and sickness at this point. So we're watching very, very closely, really, these levels. Our next steps are to expand the service and address any gaps that we still have. We want to have one point of access and triage and referral and build up more of an MDT approach to assessment. So we may bring in some psychiatry input, we may be able to offer some diagnosis, some short-term prescribing. We're not sure yet, we're working that through and whether that's the right approach. But it's also really about that supporting infrastructure. So you need managers and HR to be aware of how to manage mental health in their staff. We can provide all the psychoeducation and all the resources and the therapies and everything else, but you need the workplace context to be supportive of those staff. So we want to introduce care navigators who will help a member of staff feel supported in their workplace, understand their care plan, help them integrate into the workplace, and guide managers and HR how they can best be supported to stay in work. The lessons learned.
To ask you to wrap up soon, if that's all right.
Yeah, no problem. I'm nearly finished now, so this is the last slide. Lessons learned so far, I would say, make a compelling case, really get your exec team on board with the risk factors associated with COVID and mental health of staff. There's still quite a ticking time bomb around this, so we don't know still what the impact is going to be longer term. Preventative work now might actually prevent longer term mental health, sickness, challenges, etc. further down the line. We found it really challenging overcoming some of the barriers to staff accessing support. Being given time to access these resources in working time needs to be part of the wellbeing culture of the organisation, where staff feel safe to do this. I think there's a lot of work we still need to and want to do around this. We found things like wellbeing champions leads really empowered staff to lead on wellbeing and promote it in those areas and scale up wellbeing as a bit of a social movement. Keep planning for the long term. This is only just really the start of the recovery phase, and actually think about longer term further down the line. And finally, we found it really helpful to bring in specialists in-house, such as clinical psychologists, psychotherapists, which have enabled us to provide further support for staff. So I hope that's been helpful, just kind of walking you through our journey. We're not at the end of it. I would have a lot more to share, probably even further 12 months down the line, but this is our journey of progress to date.